they are assuming that they are going to get an opioid prescription like a tramadol, or they're going to get oxycodone or Norco or something. And if I look back in 7 years, I have not prescribed one opioid. I've never written a prescription, an outpatient prescription for an opioid. And that comes, now we've used opioids for breakthrough pain control in the hospital, but for discharge and going home, I don't. And so how do we do that?
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
In this week's episode of First Case, we are talking to Dr. Erik Pearson. Dr. Pearson is a pediatric surgeon in Las Vegas, Nevada, and he is an advocate for pain control and pain management in pediatric patients. And he is going to be sharing what he knows and what he does with us today. And Chris, it's going to be a fantastic interview.
And I will be completely honest. I follow Dr. Pearson on LinkedIn. If you don't, you should. And I am fangirling because his movement about educating the general public is really inspiring. And so I can't wait for everyone else to get to know Dr. Pearson and listen to this great conversation.
I think inspirational is the best word to say. We're going to be inspired. We're going to learn, and it's going to be a great interview. So hang on. We will be right back with Dr. Erik Pearson.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Dr. Erik Pearson, pediatric surgeon in Las Vegas, Nevada. And Dr. Pearson, thank you so much for joining us today.
Oh, I'm pumped to be here. Thank you so much for having me.
You know, you've been a guest already on our sister podcast, Beyond Clean, and I'm so glad it's finally our turn to get to interview you and have you on the show for our perioperative audience. And, you know, I follow you on LinkedIn, and I think everybody should follow you on LinkedIn. Shameless plug there. But as I was thinking about how to tackle the topic of opioids and postoperative pain management for this season, I happened to come across one of your posts, and it struck me that we can't have a complete discussion about postoperative pain control if we don't include the pediatric population in that discussion. So we're going to be talking about pediatric pain management and talking to you about your experience. But before we do that, before I jump the gun, why don't you go ahead and introduce yourself to everyone?
Well, hi, everybody. My name's Dr. Erik Pearson, like Melanie said, and I am a pediatric surgeon in Las Vegas. I've been here 7 years. I did my general surgery training at the University of Utah. I spent some time at Children's Hospital of Philadelphia at Penn doing fetal intervention research as a resident, and then did my formal pediatric surgery training at Emory in Atlanta before making the move to Las Vegas. And I've been here. I have 3 amazing surgeons that I work with in our practice, taking care of the pediatric community here. And we provide the whole spectrum of pediatric care from ECMO, congenital work, trauma, cancer, and our city is growing. So it's very exciting to be a pediatric surgeon here in Las Vegas, being part of the community. And then my passion project is scaling surgical education and building my network with people from all over the world in every different industry on LinkedIn and other social media platforms with my citizen surgeon program that I've been building. And so that's been a lot of fun. And I certainly have really enjoyed engaging with you and your team. And LinkedIn has been a really awesome kind of vehicle to not only spread what I've been learning as a surgeon over the years, but kind of learning from others on how I can apply different leadership principles and other lessons to my work. So I'm excited for our talk today.
I am too. And you really are very active on LinkedIn, but you're also very committed to educating and to sharing your experiences. So I'm excited to actually get to talk to you today. As we think about our pediatric patients, I really do think it's important to understand the unique way in which they respond to pain and how they are affected post-surgically and how they are affected by how their pain is managed. And I want to really dive into that concept today and really talk about it. But I think it's important that we start at the beginning and really just talk about pain. What does pain look like in kids? And is it the same as in adults?
That's a really good question. And this is a really important topic. It's an important topic for a lot of reasons. And not only is it important because we have had an opioid crisis in our young people and our adults throughout our country, throughout the world. You know, the recent article that published a couple of months ago in New England Journal of Medicine that while drug use is going down in our adolescents, our overdoses are going up. And, 22 teens are dying every week from overdoses, usually related to illicit fentanyl. And we're going to be talking about pain today, but one thing that I think that is an important takeaway is as physicians, as healthcare providers, whether we're nurse practitioners, physician's assistants, so if we have the responsibility and the ability to prescribe opioids, we have to give that a lot of thought because there are consequences to those prescriptions. And those consequences may be an overdose death or an addiction. And so with that being said, I wanted to now answer your question. So
Go for it.
Is pain and how does it present in kids? We see pain in our NICU and the littlest babies, and we see that all the way up through our adolescence. And in the youngest children, they can't tell you, hey, this hurts, right? And they can't tell you that they need something for their pain. It's not until you get a child that is in their late single digits or early double digits, 9, 10, 11, 12, that they can say that I need something or that they even know to ask. And so in babies, we see pain by crying, by being upset, by being tachycardic, by having, a high heart rate, being hypertensive, high blood pressure. And then as children get older, we see that as discomfort, as heightened anxiety. All of these things we have to take into account, especially in those younger children that can't communicate directly like you and I would communicate if we were in pain and wanted something for that. So as a pediatric provider, we have to pick up on these subtle cues. I remember somebody that trained me in surgery said, Erik, remember, babies whisper. Right? They're telling you these clues and it's up to us to be able to pick up on those.
So I have a question on that as well, because I think that we have like a general public audience that has maybe a different perception than what our, more surgically or medically minded are. But so when you say pediatric, what does that look like for you all? Like I obviously from, maybe birth, but pediatrics, does that define into your early 20s? I know from a pediatric family physician, it's a broad scope. Is that changing for you from a surgical standpoint?
It's a great question. And because when we think of a child, we think of 0 to 18. But as a pediatric surgeon, my specialty is not only taking care of children, but it's taking care of congenital problems. Okay, so I might have a child that's born with Hirschsprung's disease, and so they don't have a colon or rectum that functions normally. So the child's going to require not only operations as a baby, but close follow-up as that child is getting older, and that may extend into their 20s. as medicine has evolved, we've gotten a lot better at transitioning care, because physicians that are, for example, specialized gastroenterologists or cardiologists are now used to taking care of adults with congenital problems. But as a pediatric surgeon, I generally care for people or children, babies that are right at birth all the way up to 18 years of age as new patients. And then there are some patients that have congenital problems that I might follow further than that.
Awesome. It is, I think, when we think about how pain manifests, I know that there are some adults that don't, that maybe try to tough out pain and that kind of things as well. But we are seeing also that our population, and, this whole season is about opioid and misuse and how we have a responsibility as, healthcare providers. But are you seeing, are you having to, hold on, I know there's like two questions in my head and I can't figure out which one I want to ask him first. One, I want to know is, number one, are you seeing patients that are having to be educated about that, or that come to you with some preconceived notion? Because one of the biggest things as a parent for me is social media, and you use that platform to do good, but there's so many things out there that use those platforms for evil. And I think that my children have a different idea of narcotics and opioids and medication than I would have at their age. So the first question I have, and Aaron just cut me up in this, is that, number one, are your patients coming with knowledge on this? And then number two, are your parents coming with knowledge on this? Because even though you have one patient, you actually have two people that you have to, communicate with, or two groups. How do you navigate that in pediatrics? I think that's very unique to your profession.
I would say that's the best part of my profession, is the fact that I get to work with children, but I also get that responsibility, that privilege to work with the parents and being taken care of their child, right? Which I always found an extremely powerful observation when I was in training, is I would see these pediatricians that not only were they working with the children, but they were working with the parents too. And so that duality in both of those relationships are really important, because you have to be able to get a child's trust and you have to be able to get the parents' trust. And in some cases, you have to be able to do that in the moment. If I'm meeting a child in the ER and taking out their appendix, I have to establish confidence, trust, and good rapport with a handshake and a smile, both in a scared 7-year-old and in a worried 35-year-old, set of parents. And so, but getting towards pain, one of the best questions I think that a parent can ask and a child can ask is, how is my pain going to be controlled in this surgery? And that's a question that a lot of people don't ask, because they are assuming that they are going to get an opioid prescription like a tramadol, or they're going to get oxycodone or Norco or something. And if I look back in 7 years, I have not prescribed one opioid. I've never written a prescription, an outpatient prescription for an opioid. And that comes, now we've used opioids for breakthrough pain control in the hospital, but for discharge and going home, I don't. And so how do we do that?
Right. Both of us, and I wish for one moment that this was a video podcast. Never again, but for one moment, because Melanie and I both simultaneously dropped our mouths at that statistic, because you would never hear of that in the adult care world. So I'm fascinated that is your track record.
And there's a lot of ways that we can be much better in controlling pain. But if I go back to when I was an intern, if a patient had their gallbladder taken out, I would almost reflexively write a prescription for oxycodone, 5 to 15 milligrams, PO, every 3 hours. So by mouth every 3 hours. And I'd prescribe, 15 pills with a couple of refills. And that wasn't too long ago. That was in 2008, 2009. And in 15 years, 16 years, we have made a complete 180 in how we approach pain. Now, pain itself is not good, right? So when we have pain, that starts to set off all of these inflammatory cascades, these interleukins, cortisol, stress hormones. We don't want to have pain. So there is a movement that was started in the early 90s called ERAST, or Enhanced Recovery After Surgery. And that has preoperative, perioperative, and postoperative goals to not only control pain, but to get somebody ambulating and up and out of the hospital quicker, a better recovery. And so to answer your question, what I tell patients about pain before is I set expectations. And that's part of that visit, either if I'm meeting somebody in the ER for an appendectomy, or if I'm talking with a parent about their child's hernia operation, or even taking out a cancer, or doing a repair for pectus excavatum, which is a very uncomfortable operation. And I tell them, I say, well, what we're going to do is we're going to start Tylenol before you even have your operation. We may start something like a celecoxib or a gabapentin, which gabapentin is an anti-epileptic drug, but it's fantastic for controlling pain. We're going to have multimodal therapies for your pain. So we're going to do more regional blocks, like a TAP block. We may need an epidural or a spinal analgesia. We're going to be giving ongoing Tylenol, Toradol, Ketorolac, gabapentin postoperatively. And if I tell parents, and I found in my experience, if I tell parents, this is what you can expect, they no longer are waiting for that oxycodone script, because they know all of these other things we're doing. And opioid sparing surgery, opioid sparing pain control, what that means is it doesn't mean you're going to be in pain and we're not giving opioids. What that means is we have all of these other tools now that we can use so you can be pain-free without opioids, because opioids have a ton of nasty stuff with them. And I will get to that, I'm sure.
Yeah, absolutely.
Yeah, for sure. And I think it's critical to get parents on board, because no parent wants to see their child hurting. No parent wants to walk through the pain of hurting right alongside their child as they suffer. And so giving them that understanding ahead of time that we're not ignoring their pain, we are going to treat it. It's just, this is how we're treating it. And it's not maybe what you're used to, because it's not an oxycodone or a hydrocodone or a codeine, all these drugs that people think that's what we need to take. And so education is valuable and so important. But I have a question as well, because yes, you're educating the parents, but when we think about the hospitals themselves and those lovely HCAP scores and things that we can look back that drove the push to make sure patients got narcotics and got pain management so that so the scores wouldn't look bad when patients filled out surveys. How did you work alongside admin in your hospital to really have the support on that side to have a push for no narcotics after surgery?
So you need to have, I've found, to get any quality initiative through the hospital, you have to have a champion in administration. And I found a champion in administration, which was our assistant CMO at the time, Rob Smith, and he was very interested in ERAS, or Enhanced Recovery After Surgery. And he was interested. He had a background in anesthesia. He did a lot of regional blockade. And in his practice before entering administration, he had a lot of great experience with getting, down to like very little or no opioids at all in that perioperative period. And so he was my champion. And so it was easy once I identified that. The other thing was, in all of these, if you're doing any type of ERAS protocol, it's all about education on every level and finding out who all the players are. So, for example, the biggest players in my space were the surgeons. So that would be the pediatric surgeons, the orthopedic surgeons, the pediatric urologists, the pediatric ENTs, neurosurgeons, but also all of the anesthesiologists. And then it's because it's important that we're giving Tylenol or gabapentin or celecoxib in the preoperative area, that we're doing our carbohydrate loading in the morning, that the anesthesiologists are happy that the child had clears up until 2 hours before the operation instead of just making him an NPO at midnight. And then in the postoperative or and the immediate postoperative, it was educating all of the PACU nurses, having, of course, our circulating nurses on board as well. And then up on the floor talking to the neonatologists, the neonatal nurses, the PICU nurses, and the floor nurses. And so we would do kind of morning and evening educational sessions to catch people at shift change so we could talk about ERAS. And then I worked with the marketing department in the hospital to create trifold brochures. We created these little cards, which were our ERAS cards. And so they would have little check boxes. I walked 5 times today. I was able to have a diet today. And then on the back of those cards, we had, the safe discharge checklist. My pain is controlled with oral medications. I feel safe going home, all these things. So to get to your point, you said education is so important. And it's really education on every level. And it's every person that's involved in a project. And if you miss just one, if you did ERAS and you didn't talk to the nurses,
it's all for naught.
Well, then
yeah,
it's not going to be,
right.
Nothing's going to happen, because the nurses are the ones that make everything happen. Right. And so who are the people involved, and how can you educate them and get them on board? And everybody wants to be a part of something where you're decreasing pain and decreasing opioid use and improving satisfaction.
I wonder about those non-controlled environments, like within the hospital system. You've mentioned that when all of those levels of communication and education are performed correctly, that increases the care of the patient. But once that patient leaves your facility, they're in the hands of their parents. And so what does the education side look like for pain management while the child is at home? Do you educate the parents on what or how pain manifests in their, age appropriate child and what can be done with it? And do you find that there are better ways to do that than not?
Yes. And how I go about that with parents is, number one, I try to set expectations depending on what the surgery is, what to look for. For example, if I'm taking out a child's appendix, they're going to have the most pain around their belly button. All right. That's where we close the incision. And I want to tell them, well, over the next few days, if your child gets a fever, they stop wanting to eat, they lose their appetite, they get nausea and vomiting, that's when you want to call. And then when it comes to pain control, what I like to say is, I don't want you to wait for your child to be uncomfortable to treat their pain. Because if starting in the hospital, we just give Tylenol and ibuprofen, and if we need to, gabapentin. So Tylenol and ibuprofen, I'll dose and have them alternate, and just continue that when they go home for at least 3 days, usually. And then if we need to do gabapentin, we can do that. I usually dose that 10 milligrams per kilo up to 300 milligrams, and we do that 3 times a day. And I usually have to give no more than about 5 days of gabapentin if indeed I do need to prescribe that. But usually Tylenol and ibuprofen alternating, as long as we're giving that consistently, that tends to provide really good pain control. The problem is if you wait until the child is anxious and complaining of pain and crying, then it's almost too late. In that we need to start this and keep that going to get them a nice baseline pain control. So the best thing is just preventative rather than waiting, because these drugs, especially Tylenol, is very safe as long as it's dosed appropriately. Ibuprofen, I usually tell parents, we want only in ages over 6 months, but want to always take that with a meal because too much can cause inflammation in the stomach lining.
It's very helpful to know what to expect when you go home, because parents, they want what's best, but they don't always know. And so everybody can't go home with their child and they have a nursing degree or they're a doctor or whatever. And so that education, just like we talked about for staff and for while they're in the hospital, the education at home is also just as important. But also, there are really cool things that children's hospitals have that I wish adult hospitals had, and we just don't. But there are some cool ways that children's hospitals work to help children that are in the hospital with pain that are non-pharmacological. Can you talk a little bit about that?
So I think one of the best additions to children's hospitals in particular, but like you said, I wish we had it in adults hospitals, and you'd have to come up with a creative name for it, but Child Life, right? Child Life is the absolute best thing. I mean, whether it's in the trauma bay and you have the Child Life person that's going to come in with their iPad, or they're going to come in with, a lighted toy that's spinning around, they always have an age appropriate tool, toy, tool, however you want to say that, and they have the skills that they can just take that crying child and calm them down. And at one of the hospitals I work with, our Child Life people, they meet the child and the parents in pre-op, and they stick with that child all the way until they're asleep. So now while the parents can't go back to the operating room, the Child Life person who's established that relationship, established that safe feeling that this is my friend and they're going to be with me, stays with them, and then they have their iPad or they have their tool that they're going to use to calm that child, reduce that anxiety. Other hospitals are doing really incredible things with virtual reality and augmented reality. And in children, if you can distract a child and make them feel safe and comfortable, I think that goes a long way to controlling their pain, because in a child especially, anxiety is like jet fuel for pain. And if a child is anxious and scared, they're going to have pain. And it's going to be very difficult, if not impossible, to separate the two. Is this child really anxious, or are they anxious because they're in pain? And so if you haven't been able to secure that trust and reduce that anxiety, then that can become very difficult. And Child Life is just such an important part. I wish every children's hospital had Child Life, and we could call it adult life maybe, if we can.
I was about to say.
I mean, I'd like one. That'd be great.
Just these.
If somebody would hold my hand and bring me an iPad in the OR, I would be a lot happier. It would be
you could put on, whatever show you like to watch, or just sit there. We had the Star Wars crew was walking around the hospital. We have music therapy. When the rodeos in town, the Wranglers, they come and walk through the hospital. Like the Golden Knights are always walking through the hospital.
Kids get the coolest stuff. I'm jealous.
Well, and the funny thing is, so I have a few patients that have transitioned into being adults, and mom will call me and be like, "Hey, Dr. Pearson, we are over on the adult side of the hospital, and this is not good. Is there any way you can get me over to the pediatric side?" Yeah, we missed the rodeo people. We missed the clowns. I'm like, oh gosh, I'm sorry. 18 now.
Yeah, too bad.
So yeah, children's hospitals.
If you can shove him into a red wagon and drag him around the hospital, and it helps him have less pain, by God, we'll come do it with you.
That's right. That sounds good. That sounds good to me.
So, not to be kind of a bummer or a letdown, but not every patient that comes in has the best home life or had the best start. And I wonder if you see babies or children that were born addicted to drugs, whether it be opioids or the grand scheme of things. How do you go about treating those patients and protecting them, because, last season was all about advocacy. And I would imagine that you have to be a very strong advocate for that particular patient. I don't know. I almost can't
exactly
even talk
right.
because it pulls at my heartstrings so much. There's a very emotional response to it.
Yeah. And those are very difficult stories, right? When I meet those babies in the NICU, if they need surgical care, certainly our pediatricians and our neonatologists are working with these children, with these babies every day. We have, babies that are on methadone because they are born with an addiction, and it is very challenging. I mean, we are fortunate in our hospital that we have a really strong social work program, and we have a lot of great support for these families. And then if a child needs to go away from the family they were born with to a foster care family, we have pathways for that. But we also have pathways, to support that family and get them the help that they need. We have an amazing Ronald McDonald House for families that are out of town. This is kind of a different topic, different bent. But to answer your question, I'd say the important thing is the support and finding out how can we get this baby to a safe home. And we'd like that safe home to be with the parents that they were born to, but that's not always the outcome that we can have. And like I said, as a pediatric surgeon, I get to be a part of that story, a part of that child's life if indeed they need surgical care. But again, our neonatologists and our pediatricians are the ones that are working with these babies, children, and their families every day. And as you said, it is heartbreaking.
It is heartbreaking. And I will never forget, I started nursing in the neonatal ICU. And one of the first babies that I took care of on my own after orientation was a baby who had been born. Mom had been a drug user, a legal drug user on the street, addicted to crack. And that was this baby that I was tasked with caring for. And it was sobering. And it is sobering to this day to see the children that are helpless in this matter. But the opioid crisis is what it is. And it is here. And we have innocent victims that we see in our pediatric patients. But we see its effects. We see its effects on children in the hospital. We see it when they can get access as teenagers to pain medicine and to prescriptions. And then we see the results of fentanyl and everything else that is happening. And it's a sobering thought. And I hate to end this conversation on such a heavy thought, but the opioid crisis is real. So before we wrap this up, I want to give it back to you. Is there anything else, any other thoughts you want to leave us with, anything else before we wrap up today?
Well, I would like to highlight that last bit just about the opioid crisis and what we can do as physicians, as healthcare providers, as nurses, as parents in helping to protect our youth. And as providers, as physicians and providers, we can be very cautious about ever prescribing any opioids. My friend Lorraine Kelly Kwan is a pediatric surgeon in LA, and she has done an exceptional amount of work on drug diversion and opioid use and how just prescribing an opioid leads to a much higher risk of an overdose in a home that has children in it. And so if we can not be prescribing those, that's one step we can make. As parents, I think the question that I would love to hear from parents of my children that I operate on is, Doctor, how can we control my child's pain without using any narcotics? And I think that would be a really nice question to hear. And because we can do that, I'm doing that. My team is doing that, being very thoughtful about how we use non-opioid medications, whether that is, like I said, Tylenol, ibuprofen, gabapentin, celecoxib, regional blockades, and then educating and creating expectations can go a long way in not only having a child that's pain-free, but also they have really good experiences, outcomes, and high satisfaction because they don't have all of the negatives that come with opioids, like nausea and vomiting and an ileus afterwards, and, the risk of respiratory depression. So leaving on that point, I would say as providers, as physicians, we can have an effect on the opioid crisis by not prescribing opioids. And as parents, I think the question is, how can we control my child's pain without using narcotics?
And it's possible. And that to me just brings a smile on my
And
face.
It is possible.
For sure.
Yeah.
That's right.
Yeah. Just wow. Thank you. Thank you so much for taking the time to talk to us today. Thank you for sharing your experiences with us today. And I really think that this is the insights here will help educate providers who are listening and help bring hope as we move forward.
Absolutely. Well, thanks so much for having me. I really enjoyed our talk today. It always feels like it goes by in an instant, but
It does.
But I think we talked about something really important, and I hope that your audience gets some value from it.
They definitely will. Thank you so much.
You're welcome.
That was Dr. Erik Pearson, pediatric surgeon in Las Vegas, Nevada. And Chris, I realize we ended on a very heavy topic and a hard thing to talk about, but we have to talk about it. We have to talk about the effects of the opioid crisis on our pediatric patients. And we also have to understand how narcotic prescriptions can lead to abuse and addiction in our adolescent population. So I think this is such a valuable conversation to have. And Dr. Pearson really shed so much light on all the ways that they're working to make it better.
It's true. And as heavy as it was, do you know what I took away the most was that these surgeons and physicians and our healthcare staff, they have been thinking through this problem for much longer than we have been discussing it in the media. And there are so many other options other than opioids. And so I think that was hopeful because it's not just narcotic prescription or pain. It's pain-free without the side effects of narcotics. But as you said, that's going to take communication and public education. And with leaders like Dr. Pearson, I think we're well on our way to a brighter side of this pandemic and this epidemic than we were even a few years ago.
I agree. And one thing that we even heard last week in Teresa Bowling's interview is the public is getting more educated. They are learning about these things, and continued education will only mean a continued improvement in how we are managing pain. But that is going to do it for today's episode. So on behalf of Chris, myself, and the whole team here at First Case, thanks for listening to this week's podcast.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.